So we're going to be covering the surface anatomy for the dorsal hand. We're going to be first identifying some of our bony landmarks at the CMC lines, tracing out the metacarpals, and then from there drawing out our proximal, middle, and distal phalanges. From there we're going to add some of the muscular components and then go on to the volar side of the hand. So we're going to start by identifying the CMC lines, and it's easiest to follow from proximally from the fourth metacarpal to feel that little ridge. That's going to be from the identify the base of the fourth metacarpal to our distal carpal row. So we're going to come in. It's sometimes more challenging to feel this in the index and middle fingers due to the presence of a carpal boss, which is a little soft tissue swelling that can turn into an exostosis. So our little ridge that we find the CMC line may be more of a prominence. And from there, we're going to come in, and now we've identified here, this is the distal proximal row or distal carpal row in relation to the base of the metacarpals. We're going to now come in and we're going to follow in between the metacarpals, and we're going to palpate what we call a little V-notch, is where the metacarpals meet. Okay, and we'll trace out here along the edge. And here we can palpate along the edge of the second metacarpal. Okay, so we can follow these lines up here. And we can drop the line down. And so now we're defining the bases of our metacarpals. Here is our fifth metacarpal, fourth, third, and second. The second looks larger just because of the rotation of our thumb. We view it from both a radial aspect and dorsal, so it's going to look a little bit thicker. We can then follow this up, and we can palpate our joint line at the MP joint. We know that the head of our metacarpals is convex, articulating with the concave base of the proximal phalanx. So here is my joint line. Here. Here's my joint line. And here. Okay, so now we're going to come in and we're going to palpate that proximal edge of the proximal phalanx. We know this is concave, and we can follow down and palpate the PIP joint line. Okay, here. Okay, and palpate that joint line right basically in the center of the PIP joint. Okay, and now let's find the middle phalanx. And that same thing, I can feel the joint line right in the central aspect of the DIP crease. And then finally, our distal phalanx, we can palpate the proximal edge of that concavity, and then we can just bring it down toward our fingernail. So now we're going to fill in some of the muscular components. So we're going to start with our dorsal interosseous muscles. So we come in and we have two heads that make up each of the dorsal interossei. So when we come in here, these are bipinnate muscles. So they're coming off of both here, the ulnar aspect of our first metacarpal, as well as our second metacarpal. And we know that they're going to assist, they're going to join the extensor mechanism, but they're also going to have a bony attachment to the proximal phalanx that's going to help us assist with abduction. So here's our first dorsal interosseous. Now we're going to draw in, we've got two along the line on the radial and ulnar aspects of the middle finger here. So it comes in. And again, these are bipinnate muscles. Okay, and then we have the ulnar aspect of the middle finger. So the middle finger has two. So it can abduct in a radial direction as well as an ulnar one. Okay. And then we have our fourth, which is on the ulnar aspect of our ring finger. So the muscle that helps promote abduction here is the abductor digiti minimi. It does not have a dorsal interosseous. All right, so now what we're going to do is we're going to go on to the volar side. So we're going to flip over here. We're going to start with identifying, we are not going to be able to palpate the CMC lines because of our thick fascial tissue in the palm. However, we can palpate the joint line here of the MPs, and we're going to mark that and follow that down until we can no longer palpate the shafts of the metacarpals. So I'm going to come in here. Here is my second metacarpal. Okay, and the fourth. Okay. And the fifth. So we're going to bring these down just a little bit so we can identify some of the muscles that come off the volar aspect of the metacarpals. Okay, now we palpate our proximal phalanges, and we can draw those out as well. So we're just going to draw out the proximal phalanges here on the volar side, and then we'll start filling in some of the muscles. Okay, good. So now let's fill in our volar or palmar interosseous muscles. So these muscles, we have 3, and they're responsible for adduction of the finger. So when we look at the dorsal side, if he spreads his fingers apart, we can appreciate how the dorsal adductors, they function, the dorsal interosseous, to abduct the finger. When he comes back, you can see them contract as he abducts. Now, when we look on the volar side, we are going to have 3 volar interossei, which are going to help adduct or bring his fingers together. So we're going to have one that's going to come along the ulnar aspect of the index finger. These are unipennate muscles, meaning they only have one set. They don't come off both metacarpals. And it's going to come up, and these are going to assist in, they're going to join in our extensor mechanism. And now we're going to come in here, and we're going to do the radial aspect of the ring finger. We do not have any volar interossei or palmar interossei on the middle finger. And then the small finger. So now we're going to draw in the flexor digitorum profundus tendons, and they're going to run right along the central aspect of our metacarpal and proximal phalanges. Okay. From there, we're going to draw in now our lumbricals, and our lumbricals run on the radial aspect of the FDP tendons, and their function is more proprioceptive. They do assist with IP extension, but their primary function is proprioception. So they also just assist slightly with our MP flexion as well. And we're going to bring those up here so they start and end from the FDP tendons. Come in. So this is our lumbrical muscles on the radial side. They're Latin for worm. They kind of look like little worms. Okay, great. We're going to go through the surface anatomy now for the finger, going through our flexor surface. So we come up. I'm going to just extend just the middle finger all the way to the end, the FDP tendon itself. Now we have a place called Camper's chiasm where we have the FDS splits, and it actually rotates 180 degrees, the slips. So the FDS is going to help us with MP and PIP flexion, but it does not continue to the DIP. So this is where Camper's chiasm is, where we have that rotation of the slips of the FDS. Okay, all right. And now we're going to fill in some of our pulleys. So we have 5 annular pulleys and 4 cruciate pulleys in our fingers. So we find the A1 pulley is right at the MP joint. So here's the A1 pulley here. Our odd numbered pulleys we're going to find those at the joint. So the MP joint here, A3 pulley is going to be right here, and A5 here at the joint. We also have annular pulleys, the A2 and A4 pulleys, which are our most important pulleys to prevent bowstringing. Between those annular pulleys, we have the cruciate pulleys, and they're much more flexible. So these are little X's that go in between the annular pulleys. Okay, so there's 4 cruciate pulleys and 5 annular pulleys in the digit. So now on the adjacent finger, we're going to draw on our volar plate. So our volar plate especially at the PIP, serves a large function to help us to maintain stability of the PIP joint, especially with hyperextension forces. We have Sharpey's fibers where they attach the bone. That makes for a very strong attachment. When the volar plate fails, it tends not to fail at the proximal phalanx, but it tends to fail at the middle phalanx at its insertion point. So we have volar plates at all three joints. It's least developed in the DIP, but serves a crucial function at the PIP as well as the MP joints. So now I'm going to turn his hand and I'm going to draw out the collateral ligaments. So we have proper and accessory collateral ligaments, and they are fan-shaped structures. So the PCL, or proper collateral ligament, is going to arise off of the proximal phalanx, and it's going to be a fan-shaped structure attached to the middle phalanx. The proper collateral ligament is a much stronger structure than our accessory collateral ligament. Our accessory collateral ligament is a little bit more wispy, and that comes down and that attaches, the accessory collateral attaches to our volar plate right here. So we have, to promote stability at the PIP, we have on each side, we have the proper collateral ligament, which is a fan-shaped structure to provide lateral stability throughout the arc of motion. We have the accessory collateral ligament, and we have that strong volar plate. So a three-sided box to help provide support for the PIP joint. So now we're going to come back and we're going to look at the extensor surface of the digit. So we're going to start with our EDC tendon. So if I'm going to have him come up into a claw, you can really see those tendons become more prominent. So we're just going to do the middle finger. So coming in here, so here we have the extensor digitorum communis. After it crosses the MP joint, it's going to split or trifurcate into three. Okay, so go ahead and relax for me. So here's where we have a medial and lateral slip of the EDC, and we have a central slip. And the central slip is responsible for PIP extension, while the medial and lateral slips of the EDC, they are going to join the interosseous muscles and lumbricals, and they're going to form the conjoined lateral bands, which are going to assist with PIP and DIP extension. So now we have a structure on the back called the sagittal band, and what that sagittal band is responsible for is centralizing that extensor tendon. So that's going to come across right here. And sometimes people that have sagittal band ruptures, you see that extensor tendon start to sublux off the side of the metacarpal head. So just distal to our sagittal band, so we have two sets of structures. We have the transverse and the oblique interosseous fibers, and they assist with flexion of the MP joint. So we're coming in, so here's our transverse. A little harder to see. Let me get a different color here. Okay, our transverse here, interosseous fibers, and then our oblique. So our oblique interosseous fibers coming along here, assisting with MP flexion. Now, this is my favorite part. This is so fun. So here's where we can see the extensor mechanism is a blending of extrinsic and intrinsic elements. We saw the extrinsic elements with the EDC coming up, and then the medial and lateral strips. Now we join what we've drawn out with our dorsal interossei, volar interossei, and lumbricals to form the conjoined lateral bands. So we're going to come in, I'm going to use purple here. So we take, here we have the contribution, and actually let's make that blue. There we go. So here we have the contribution of the dorsal interossei coming up, joining the lateral band On the other side as well, coming up, joining the lateral band. We have from the volar side, we have here our lumbrical. So our lumbrical is going to come up and it's going to join the lateral band here. Okay, so these three structures, if we're looking at the radial aspect of the hand, we have the dorsal interossei that's going to come in. We've got, so this is going to continue on up here to assist in forming the terminal tendon. We have the EDC coming in together, as well as our lumbrical. So this structure here, the lateral band. And the lateral band is important, and we're going to talk about its travels dorsal to the axis of rotation. And I'm just going to mark here the axis of rotation of the joint here. So here's the axis of rotation. Okay, and let's do the other side. Here and here. Good. Okay, so we've got the radial side. We have the lumbrical, we have the dorsal interosseous, and we have the EDC. Intrinsic, intrinsic, and extrinsic joining together to form the lateral band, going dorsal to the PIP joint axis, and continuing on to form the terminal tendon. Now we're going to get the ulnar aspect. So we've already pulled the dorsal interosseous and the EDC. We don't have anything else on the ulnar side, so it's just those two structures coming up. So let's pull those through. So here, coming in, this is going to come up on the ulnar aspect of the finger. So here's the lateral bands, and they're joining and coming up. Okay? So it's the lateral bands and that contribution of intrinsic and extrinsic elements that helps form the terminal tendon that promotes DIP extension. So now let's talk a little bit about some of the ligamentous support. So we have the triangular ligament, and we find that between the contribution from the lateral bands, the medial and lateral slips, that triangular ligament is going to be really, really important to help us to keep those lateral bands in place. So we also have the transverse retinacular ligament. They also have an important function to keep the lateral bands in place, and if they stretch out here, we end up with a swan neck deformity. So let's draw this out here. So this is the transverse retinacular ligament here. Okay, and then we have one on the other side as well. So if we end up having, let's say, the volar plate stretches out and this stretches out, we can end up with a swan neck deformity because these now sublux too much dorsally and it hyperextends the PIP and it causes resultant flexion of the DIP. If the triangular ligament stretches out, now those lateral bands shift volar to the PIP joint axis, and that can cause what we call a boutonniere deformity, PIP flexion deformity with resultant hyperextension of the DIP. Okay, we've got one more structure that we're going to identify. It's called the oblique retinacular ligament, and that ligament is responsible for assisting with DIP extension. It comes off the volar plate, and it comes up, and this ligament has many different names. It's sometimes called the spiral oblique retinacular ligament, and then also called the ligament of Landsmeer. So lots of different names for the same structure. It's going to assist also with DIP extension. In a boutonniere deformity, though, this can sometimes get contracted where patients are going to have difficulty performing DIP flexion. For that reason, when we splint someone in terminal extension at the PIP in a boutonniere situation, we want to place the DIP in slight flexion to keep that oblique retinacular ligament slightly on stretch. So we've covered all of the critical anatomy from the dorsal hand in through the extensor mechanism, so we can appreciate how intricate that extensor mechanism is and the blending of intrinsic and extrinsic elements. We've covered the volar side of the hand and appreciating why that palmar tissue is so thick. We have many layers of different muscles. Not only the flexor tendons coming through, but we have the volar interosseous muscles as well as the lumbricals. We've covered the pulleys in the finger, the annular and cruciate pulleys, as well as the volar plate, the proper and accessory collateral ligaments, and then finally our triangular ligament and retinacular ligament and spiral oblique ligament.